Good morning, everyone. Thank you so much for joining us for the third annual Fellows Debate. Is this the third one? So I am Kelly Beers. I'm a nephrologist at Albany Med, and I had the pleasure of working with Lucas Schmidt this year on the trainee activities. So this is sort of the final very exciting trainee activity that we have, other than our recap this afternoon at 4:30 for anyone who's still around. So the format of today's debate is going to be 20 minutes per team presenting their argument, and then we're going to give each team 2 minutes to prepare a rebuttal, 3 minutes to deliver the rebuttal, and then we'll take questions. So we would like, if you have questions that you want asked during the question period, please put them in the app, and then we'll pick our favorite questions to ask the teams, and then we'll have some judging. So we have a panel of esteemed judges up here in the front. We have Dr. Sylvia Rosas, and we have Dr. Jeffrey William, and Dr. Julia Ciela. So thank you so much for joining us and judging. I'm going to introduce the teams. Let's see. So our first team, actually I should pull up your slides here. All right. Our first team is our so the topic of this debate is to plex or not to plex. That is the question. And our first team is team no plex. So we have Dr. Deepchan, oh God, guys, I'm going to kill all your names. I am so sorry. Dr. Jain is a second-year nephrology fellow at the University of Pittsburgh Medical Center and will begin a transplant nephrology fellowship at Emory in July. While his long-term career plans remain to be determined, he intends to settle in the United States and pursue a combined practice in general and transplant nephrology. And then we have Dr. Ahmed, a first-year fellow at LSU Shreveport. Their clinical and academic interests include electrolytes, AKI, and glomerular disease. And, oh no, he's on my team. Sorry. I'm just reading this wrong. Wait, that's not right. It is, yeah. I'll just read everyone. You'll figure out what teams they're on, since that's what I'm doing anyway. Dr. Nadajaran is a second-year nephrology fellow at Mount Sinai Hospital. He completed his internal medicine residency at the University of Oklahoma. His clinical interests lie in transplant nephrology with a focused interest in recurrent GN affecting kidney allografts. And then we have Dr. Wirasiri, who is a first-year nephrology fellow at Duke. Her research and clinical interests include medical education and sodium disorders. Dr. Elbaz Yunis, God, you guys, I'm so bad at this, I'm so sorry. Board-certified physician with dual fellowships in geriatric internal medicine and nephrology. With more than 2 decades of clinical, academic, and research experience across internal medicine, hepatology, gastroenterology, and infectious disease, he's committed to advancing patient care and medical education. He's currently a nephrology fellow at the University of Houston, actively involved in clinical research, scholarly publications, and national conference presentations. Sounds like he might be cheating. Is he really a fellow? And then finally, we have Dr. Jimenez, a PGY4 at BCM, who is passionate about advancing equitable health care and the intersection of social determinants of health with the care of patients with chronic kidney disease. Originally from Brownsville, Texas, she graduated with honors from St. Mary's University in San Antonio, earning a bachelor's degree in biology with a minor in chemistry. She went on to attend Texas A&M College of Medicine, where she obtained both her MD and Master of Science in Medical Sciences, focusing her research on immune mechanisms for developing therapies for advanced ovarian cancer. And during medical school, she co-funded a free clinic for homeless youth in Houston, then completed her residency at Duke. This year, she will serve as the ASN DEI committee intern. She enjoys working out, gardening, and hiking with her dog. All right, so without further ado, we are going to have the first team come up. I'm going to be keeping track of time on my phone, and we will hold this up and give you a 5-minute warning. And then when we say time's up, you just have to stop talking. All right, so let's welcome team NoPlex.
All right, hi everybody. My name's Yahaira Jimenez, and like they were saying, I am a first-year nephrology fellow at Baylor.
Hi everyone, this is Sharif Elbaz, second-year nephrology fellow, University of Houston.
And I'm DJ, I'm from UPMC Pittsburgh, second year as well.
And we're team NoPlex. So for starters, we have no disclosures. But we'll start by reviewing the pathogenesis of ANCA-associated vasculitis. So here you'll have a trigger such as a genetic predisposition, infection, any sort of drug exposure that's going to prime your immune system, while you have this ANCA antibodies that are going to activate neutrophils and leading to neutrophil extracellular trap production and eventual vessel injury. Now you have Plex that's going to help with removing these antibodies. It's going to help with removing some of the inflammatory cytokines. You have, but in general, you still have the inflammation that's ongoing. You have several approved therapies which are going to help inhibit B-cell activation, help inhibit some inflammatory cytokine production, and then you have your C5a inhibitor in avacopan. And the two asterisks there are just given the recent controversy surrounding the drug. And then lastly, there's a lot of things that are coming through the pipeline. You have a lot of investigational therapies that are coming. You have several therapies that are targeting B cells through BAFF inhibition, lymphocyte stimulation, APRIL inhibitors, CAR T cell therapy, and then you also have complement activation inhibitors. And then further, you can kind of compare the pathogenesis of ANCA with something like an oil spill. So you have these ANCA antibodies that are kind of like the oil here, and this is the Deep Horizon spill. And when 2 out of 3 people in your debate team are living in Houston, this kind of hits close to home. So here, the oil is going to keep spreading, and it's going to end up targeting some of your organs, some of the marine life, some of your ducks and turtles that are around there. And you can take care of the spill one of 2 ways. You can skim it, which is your Plex, and you still have oil that is going to continue to cause havoc, or you can fix the spill, and you can control the underlying inflammation. So this is using therapies like rituximab, like cyclophosphamide. So this is kind of your underwater welder that is going down there and soldering the pipe, and it's actually going to address the root of the problem. And Plex is not just a Band-Aid, it also comes with a lot of complications. You have procedure-related complications. You have hypotension, drug removal. You have citrate-related complications with hypomagnesemia, hypocalcemia, which can lead to arrhythmias and patient discomfort. You have replacement fluid-related complications like transfusion reactions, coagulopathies, infection, hypervolemia. And then there's patient preference. You have patients that have religious beliefs against blood products or contraindications to coagulation. And when you take a step back, you also have to think about the juggling of timing when you have a patient that needs rituximab, needs Plex, and then also needs to have dialysis. So you have to coordinate with all these teams to get the timing right for all of these procedures.
Now we have breaking news. Let's talk about the data. MIPEX trial, done in Europe 2007, was designed to find a better way to save the kidney in patients with ANCA vasculitis. As we know, ANCA vasculitis, one of the major causes of rapid progressive GN. Patients with advanced renal failure, their prognosis is poor. There is at least 50% risk of either death or permanent dialysis within first year. The study enrolled 137 patients with recently diagnosed ANCA vasculitis with serum creatinine more than 5.8, biopsy-proven post-immune GN, age between 18 and 80 years, without overlap syndrome, without life-threatening diffuse arterial hemorrhage or history of dialysis, history of immunosuppressive before or GN. Technically, it compared 2 groups. One group received plasma exchange and another one received high dose of intravenous methylprednisolone. Both groups received standard therapy in form of cyclophosphamide and oral steroid. As we can see, this was a very sick renal cohort in a study designed to see if the plasma exchange can help this population. How about the results? Primary outcome looked at dialysis independence at 3 months, which shows significant increase in recovery rate in patients receive plasma exchange compared to intravenous group. This also benefit continue at 12 months. Risk reduction was 22% at 3 months and 24% at 12 months. The results were statistically significant. However, the confidence intervals were wide, likely due to small sample size. How about the survival rate and the mortality rate? There was no significant difference in patient survival, and the mortality remained high in both groups at 12 and at 3 months and 12 months. Although the results show favorable outcome in plasma group toward dialysis independence, the study was small, didn't include rituximab or other modern new therapy. Globally, this might improve the kidney outcome, but there is no significant difference in survival rates, and the mortality remained high in both groups. This reminds us, while plasma exchange saves the kidney, it doesn't change the high mortality risk in this sick population.
Then came the Pheresis trial in 2020, which was the largest cohort of ANCA patients studied in the last 2 decades or more. They had 4 arms by a 2x2 factorial design, wherein one arm received plasma pheresis, 7 sessions over 14 days, and the other arm received no plasma pheresis. The groups were further divided into a standard dose glucocorticoid regimen and a reduced dose regimen. This was performed in 16 countries, 95 centers. A total of 704 patients were enrolled. The pertinent inclusion criteria was severe renal involvement with a GFR below 50, an active urine sediment, or a biopsy revealing necrotizing glomerulonephritis. Of note, they also included pulmonary hemorrhage or diffuse alveolar hemorrhage in their inclusion. The exclusion was pertinent for dual positivity for GBM and ANCA, dialysis within the preceding 3 weeks, prior Plex, cyclophosphamide, or prednisone use in the preceding month. And all patients were treated or induced with cyclophosphamide or rituximab. As you can see, rituximab was not available near the MAPEX trial, but newer therapies started coming along later. The pertinent baseline characteristics, as we can see, they did include patients with a creatinine of greater than 5.8, which was similar to the MAPEX study. And if you pay close attention to the numbers, 101 patients in the Plex arm, 104 patients in the no Plex arm. When you combine them, that's even more than the entire cohort taken for MAPEX. The incidence of diffuse alveolar hemorrhage, severe and non-severe, was around 28%. Although it was not statistically significant as per some critique, it is what we see in clinical practice. The incidence of DH is around 10 to 25%. Coming to the primary outcome, it was a composite of death from any cause, or ESKD, at 12 months, and in both arms, with or without Plex. And as we can see by this Kaplan-Meier curve, there was no significant difference in the outcome. Coming to the secondary outcomes, which was the primary outcome split, individually, death from any cause, ESKD at 12 months, sustained remission, adverse events, and serious infections at 1 year. As you see, all of them crossed 1 and were not significant. Unlike MAPEX trial, ESKD, although it was less significant in MAPEX, in the Pheresis, you see it crosses 1, so that goes against MAPEX study. Coming to this, the severity of kidney disease did not affect death from any cause or ESKD outcomes. I would like you to pay attention to the second column, which is patients requiring dialysis or with a severe renal involvement, which is a subgroup analysis comparing to the cohort seen in the MAPEX study. And as we see, although it favored Plex, it did not cross significance. This is a post-hoc analysis which was reported in 2025, and they stratified the cohort of renal patients by GFR. And if we start by a GFR greater than 30, although there was some early improvement in the cohort with Plex, and it lasted until 26 weeks. By the time we reached 52 weeks, it almost reached a point of no significance. Similarly, in the GFR from 15 to 30, although there was some initial benefit noted at 4 weeks, as time proceeded, it started to level out. And coming to the last one, which is the most important one for us, is a population with a GFR below 15, and this is a cohort similar to MEPEC's study. And as we see, 21% versus 26% at 4 weeks, so slight improvement, but at 52 weeks, it almost goes below the no-Plex group, which further confirms the concept that it does not help in ESKD incidence at 12 weeks if you do Plex or not.
All right, and now we can take a look at the real-world data. So proponents of Plex argue that the patients in the Pexivast trial didn't need a kidney biopsy to be included in the study, which is a huge point of controversy when you're thinking about plexing a patient or not plexing them. So this is a study from 2024 that included 2 different hospitals. It reviewed data between 1996 and 2021, and this patients had to have a kidney biopsy. These are patients that have eGFR less than 15. It included 166 patients. And when they looked back at the data, they realized that ESKD outcomes, renal recovery, and dialysis discontinuation were the same amongst groups treated with or without Plex. So this being a retrospective study, you can probably assume that the patients that received Plex were generally sicker because the decision of plexing or not was left off to the provider. But this tells you that even in the sicker populations, you still don't see a benefit in plexing patients. And the main predictor for dialysis discontinuation in this patient it was interesting that they found that patients that had minimal chronicity changes on the biopsy and lower creatinine at diagnosis were the ones that had the renal recovery ESKD. So again, it didn't really matter whether they got Plex or not. And the other interesting factoid is all these societies actually softened their recommendations after the Pexivast trial came out. So the American College of Rheumatology, or ACR, recommends against routine use of Plex, but you can consider it if a patient has RPGN, dual anti-GBM positivity, or for salvage therapy. KDIGO recommends against Plex if patient has GFR less than 50 at presentation, but you can consider it if there's RPGN or the serum creatinine is greater than 3.4. The European Alliance of Associations for Rheumatology, EULAR right here, they downgraded the recommendation in 2016 from recommend to may be considered in 2022, primarily for RPGN or dual positivity. And then you have the British Society of Rheumatology, which limits their consideration to a creatinine greater than 5.6. Now, the American Society for Apheresis actually publishes their recommendations every 3 years. So they published their recommendations in 2019, and then Pexivast came out, and they reconvened months later. And they lowered the recommendation from a Category 1 with RPGN to a Category 2, which is just recommended. And when you look at the DAH specifically, this is where recommendations shift. And the American Society for Apheresis, or ASFA, is the only organization that recommends plexing patients in DAH. Everybody else recommends against it. So really, when you take a step back and you review all the data that we showed you, all the associations, all the real-world data, you see that Plex doesn't really alter the outcomes in mortality, doesn't really make a difference with ESKD progression or dialysis discontinuation, and you don't see a benefit in mortality. There are caveats, and we recommend against Plex in the majority of patients who present with ANCA vasculitis. What are those caveats? I want you to imagine a bell curve. And on the x-axis, you have disease severity, and on the y-axis, there's going to be the number of patients. The majority of patients are going to be in that 80% middle curve. Those are going to be the patients that we're going to see in the hospital. But here, everybody on this side are the patients that have been on the MEPEX trial, on the Pheresis trial. And again, there's really no difference in outcome in this patients. We've largely failed to show any meaningful benefit from Plex. The real controversy lies over here on the right side of this tail, which is where you have your DAH patient who's about to get intubated, where you have your RPGN patient who might need CRRT or might need dialysis. Those are the patients that most of us would agree that Plex might be reasonable. And that is kind of what we recommend in this case. Those patients who are sick with RPGN, life-threatening DAH, and specifically because you're not going to find any RCT trial that is going to include these patients who are this sick. We did see some trials that we showed you, but again, none of them are going to be powered enough to show whether there is a meaningful benefit in these patients or not. But in general, we recommend that you turn off the spill and don't just clean it.
Thank you.
Thank you.
And just FYI, pro Plex team, the previous team decided to all stand, but feel free to sit down, that's okay.
Okay, do I just get started? Good morning, folks. My name is Samadi Weerasiri. I'm one of the fellows at Duke. I'm joined by my co-fellows, Mohammed Ahmed from LSU Shreveport and Hari Natarajan from Mount Sinai. At the end of the day, in our patients with vasculitis, the spill has already happened. We can plug up the source, but who's going to clean the ducts? We're here to share our presentation supporting the benefits of use of plasma exchange in ANCA vasculitis. And before I move forward, I also want to thank our mentors who are featured here, who were really critical in the development of this presentation. We similarly have no disclosures other than the scant use of open evidence to assist with our literature search. Now, the literature that is available on this topic is extremely nuanced, and our goal here today is not to convince you that plasma exchange represents a silver bullet in the treatment of this disease, but rather that it does have a role in addressing our most severely affected patients. The main thrust of our argument today is going to come in three main waves. Number one, that vasculitis is an antibody-mediated disease, and it makes theoretical sense to use plasma exchange to address this. Number two, we'll include a review of the literature with special attention to the limitations of the Pheresis and meta-analysis trials that are available to us. And lastly, we're going to take plasma exchange out of the context of the trials and talk about some of the practical applications and observations of using this therapy in the real world. Now, I want to touch on the evolution of our guidelines. Our opponents shared at a single snapshot in time that the recommendations are divided, but you'll see here that when you look temporally over time, there has been a decline in the threshold that's recommended to initiate plasma exchange. Now, these recommendations also comment on the use of plasma exchange or the lack thereof in diffuse alveolar hemorrhage. And ultimately, this is a nephrology conference, so I'm not going to focus on this today. I do want to note before we go forward that these are practice points. These are not graded recommendations, and this is reflective of the heterogeneity of the evidence available on this topic. Very broadly speaking, the natural history of vasculitis is one that is riddled with morbidity and mortality. In this cohort of vasculitis patients, and specifically those who have progressed to hemodialysis, represented in the pink, you can see that 50% of those patients have passed away at 5 years. It is our obligation to be aggressive in the treatment of this disease. Now, when it comes to pathogenesis, my graphic here looks very similar to our opponents. There's only so many ways to reinvent the wheel. So generally speaking, there is some sort of inflammatory trigger that leads to translocation of PR3 and MPO antigens to the cell surface of neutrophils such that they're able to interact with ANCA antibodies. From here, as our colleagues reviewed, there's an inflammatory cascade that ensues with release of reactive oxygen species and lytic enzymes that leads to direct vessel damage. Now, our opponents really nicely outlined that there's other therapies and emerging therapies to help address antibody creation, but what they didn't tell you is that it takes time for those therapies to work. Imagine that you have access to a therapy like plasma exchange that's able to clean up these antibodies up front so that your therapies have time to work. Now, we also have reasonable evidence that these antibodies are not just markers of disease, but are in and of themselves pathogenic. Here, I'm presenting a mouse model that includes a strain of RAG2 negative mice. These are mice that are unable to perform heavy chain rearrangement and thereby are unable to generate functional T cell receptors and immunoglobulins. These mice are then exposed to varying concentrations of anti-MPO IgG and control IgG. Specifically, if you're able to see my mouse, you may not, but the gray coloration indicates the most concentrated formulation. Oh, it's fine. And the black represents the most dilute formulation. And you can see that across the groups, there's almost a dose-related increase in BUN and creatinine as you increase your exposure to the pathogenic antibodies. This implies that the presence of these antibodies help to mediate disease. We also have human evidence of this pathogenesis. This case report describes a young pregnant female with known history of MPA vasculitis who presents to the hospital with hypertension and shortness of breath. There was concern that she was in a vasculitis flare, and during the admission, she gave birth to the baby. On the day of delivery, you can see that the concentration of p-ANCA IgG was identical between mom and baby. Baby went on to develop pulmonary renal syndrome and was ultimately treated with steroids and plasma exchange. Now, this is significant because we know that babies do not have any inherent adaptive immunity. The exposure to the ANCA IgG was derived transplacentally from mom, and it seems like this led to the development of disease in the neonate. We also know that the quantity of antibodies has bearing on the disease progression of these patients. In this cohort of vasculitis patients, the investigators found that those who were in serologic remission, represented by the green, were statistically able to have doubling of their GFR and greater chance of renal recovery at every observed time point when compared to their counterparts who had recurrent or persistent antibodies that are in red. So taken together, this all indicates that antibodies are indicated or have a role in the pathogenesis of this disease, and it's worth our while to clear them.
Now that we have seen why PLEX should work in the ANCA vasculitis, let's see how that's translated into the clinical trials. So over the 3 decades we had multiple trials, as you can see. The green ones show benefit in ANCA vasculitis, the purple ones show no benefit. But the devil is in the details, so let's examine the most important 3. MEPIX was done when the most severe kidneys with creatinine more than 5.8. They did a kidney biopsy, 60% crescents in the cohort. They saved the kidneys, as our opponents has said, risk reduction about 24%. That means 1 out of every 5, you're gonna save the kidneys. So imagine during my year in the fellowship, I can save 1 out of 5. Maybe I should put it on my resume. They also pointed out that while they showed some renal recovery, they did not impact survival. But we are nephrologists. We also care about both the kidneys and the patients. So we need to keep both alive as much as we can. So let's uncouple renal recovery and mortality. Every nephrologist wants their patients off dialysis. But mortality is affected by a lot of other factors: vasculitis burden, infection, treatment toxicity. These are not, PLEX is not designed to fix everything. And the absence of a mortality signal does not make a kidney-specific signal clinically irrelevant. While, as I see it, PLEX may not change the date on the death certificate, but it's going to keep you away from Monday, Wednesday, Friday schedule. Pheresis enrolled a larger population, but they enrolled weaker, less sick kidneys. They only used creatinine of 3.6. They did not do a kidney biopsy. They used a composite outcome of ESRD and death, so the outcomes may be diluted there. And when you look at the patient population, they are not the same. Pheresis enrolled a median of 3.7. Only 20% required dialysis, while MePEX required 70% of these patients required dialysis upon entering the trial. So they asked completely different questions. MePEX was asking, how can I save the kidney right now? While Pheresis was looking at the long-term survival. And inside Pheresis, the sicker kidneys actually hinted for a signal for the kidney. Only a third had a creatinine of more than 5.6, but we think these results have been diluted by the other outcome. And then in 2022, Walsh and his colleagues did a meta-analysis of the 9 trials that had been published with more than 1,000 patients. And it showed 40% risk reduction in ESRD. Well, most sick kidneys had the best benefit. Well, usually when you get a meta-analysis with a positive outcome, you get a grade 1 recommendation in the guidelines. But that did not happen due to the increased risk of infection. But I think this requires more analysis. And I'm going to let my colleague discuss it further.
Well, up until this point, we understood how antibodies play a role in the pathogenesis of the disease and how removal would make sense. But the clinical evidence for the use of PLEX is very heterogeneous with hints towards positive renal outcome benefits. Well, I'm going to focus on 2 points of practical consideration, and I promise at the end of this, you all are going to view PLEX more positively in the use in ANCA vasculitis. You're going to save more kidneys, and we are going to win the trophy. Let's focus on the first point, whether the dose of plasma exchange was adequate or not. The Pheresis guidelines recommends that we use 1 to 1.5 plasma exchange during plasma exchanges for vasculitis, and why the dose of 1.5 was chosen was because it removes around 78% of circulating immunoglobulins. Here I must emphasize this is the circulating immunoglobulin. We are not removing the 50% that is extravascular. In both the MePEX and the Pheresis study, the dose that was chosen was 60 mL per kg for 7 exchanges over 14 days. And this was based on a consensus. There's no evidence supporting the use of this dose. And it was also based on the understanding that this would be approximately 1.5 plasma volume exchange if the hematocrit is normal. But we know that most of our vasculitis patients also have anemia. The median hemoglobin in Pheresis was 9.5, and there are several cohorts where the prevalence of anemia is as high as 100%. And coexisting anemia would lead to underdosing of PLEX. So I just have an illustration for this. Let's imagine a 60-kilo male with a hemoglobin of 8. By doing a 60 ml per kg exchange, we would be giving a 4-liter exchange. But if we actually do the plasma volume calculation, then this would be around 5-liter exchange, meaning that by using the 60 ml per kg, we are like underdosing by 20%. Whether this is clinically relevant or not is a question that you might arise, because it still falls within the window of 1 to 1.5 exchange, but we do not have evidence to see if this dose of 60 ml per kg translated to removing the antibodies, because there was no antibody titers that was checked in both MePEX and the Pheresis study. In fact, there is no evidence that we have to support that the 60 ml per kg exchange over 7 doses in 15 days would remove the antibodies. I have a case report from 2023 where it did 3,000 ml plasma volume exchange, which was around 1 plasma volume. And after 6 exchanges, there was only 11% reduction in the level of antibodies. And they did do subsequent exchanges, and they used IVIG along with it. Like, we're not going to dwell into the IVIG part, but you can see after increasing the exchanges, the antibody removal is as high as 62% after 9 exchanges. There was a study where they looked at 7 patient case series, but they did more aggressive plex where they completed a 60 ml exchange within 10 days. And here you can see when they did it more aggressively, they were able to remove the antibodies. But even over here, if you look at patient 6 and 7, the amount of antibody removal was not the same. And what I want to emphasize here is that the fixed dose and fixed number of exchanges might not relate to the same amount of antibody removal in patients, and this is where checking the antibody titers might be very crucial. Many of you may be able to relate to this, especially today morning. This is how I view plasma exchange was done in both MePEX and Pheresis. They used a very bad umbrella in a storm of antibodies, and even by doing very bad plasma exchange, we could see renal benefit. Just imagine if you do proper plasma exchange, how the benefit would translate. So now moving on to the second point, the observed infection risk can be directly attributed to plex. So this is the evidence that we have from the meta-analysis. We know that there was increased risk of infection, but if we look closely, this increased risk was driven by one study, which is Walsh 2020, which contributed to 83% weight and a risk ratio of 1.28. But this is where it gets interesting. The Walsh 2020 is in fact the Pheresis trial, and in the original Pheresis study, there was no statistical increased risk of infection. This is because the data was analyzed differently. In the meta-analysis, they used a risk ratio, and in Pheresis, they used incident rate ratios. And for those in the audience who understand statistics, incident rate ratios take into consideration percent time years and is statistically more rigorous. And from what I'm looking at, I don't have enough evidence to say that plasma exchange increases the risk of infection. But biologically speaking, I do understand how plasma pheresis can increase the infection risk, especially if you use 5% albumin exchange, because this will remove immunoglobulins complements immunomodulation. So if you are using 5% albumin, I do believe that we should check the immunoglobulin level and replace with IVIG when low. KDIGO 2024, in fact, recommends checking immunoglobulins when using rituximab. So if we are doing it for rituximab, it just makes sense that we should do this for plasma exchange as well. The MePEX and Pheresis trials also did not mandate using PJP and fungal prophylaxis, which I think is really important. Also, there's an important point to note here. Immunosuppressive effect of plasma exchange is short-term. Even if you use 5% albumin exchange, this is only for a few weeks and maybe a few months. An infection risk over 1 year period cannot be fully attributed to plasma exchange. So this is a study that was done with neurological patients after 5 plasma volume exchanges. And they noted that the immunoglobulin level did drop significantly, but came back up after 5 weeks, especially for the IgM and the IgA levels. IgG did take time to come back, but we should take this with a grain of salt. But because these patients did not receive cyclophosphamide or rituximab, our patients do get a lot of immunosuppression, and this is where it becomes very crucial to check the immunoglobulin levels.
All right. Let's bring it home and synthesize all of this information. So today, our team advocates for the use of plasma exchange in our most severely affected vasculitis patients. Of course, our opponents have argued today that there's not enough evidence to support plasma exchange in this setting, but our position today is that we just don't have access to a properly designed randomized controlled trial to help us really judge the benefits and risks in the most vulnerable subgroup of this disease population. So to this end, our group has devised an ideal randomized controlled trial that will also integrate our main takeaway points from today. So in our ideal trial, we're going to include the patients who have most threat of organ failure. These are patients with creatinine greater than 3.4 milligrams per deciliter or are already on dialysis, with a primary outcome of their dialysis status at 12 months. And we will purposefully separate that outcome from other parameters like mortality, risk of relapse, and infection so that they can be judged independently. Those patients will then go on to receive standard induction therapy and then randomization to plasma exchange or no plasma exchange. Let's focus on our protocols for plasma exchange in this hypothetical study. All patients in the intervention group will receive a prescribed dose of Plex of 1.5 plasma volumes. This will ensure that we account for the ubiquitous low hematocrit that we see in these patients, and it will ensure that they're adequately dosed. Much like we do in the treatment of anti-GBM, we will also check antibody titers after treatment to ensure serologic remission. If this isn't achieved, then we'll modify the prescription of Plex so that serologic remission is achieved. In addition, as we discussed, we are also going to have standard protocols for all Plex patients to receive infectious prophylaxis. These are infection mitigation strategies. And we're also going to advise that immunoglobulin levels are checked before and after the course of plasma exchange for consideration of IVIG as we would in our transplant patients who are being treated for ABMR. That concludes our talk today. Thank you so much for your attention. We look forward to questions.
Now it's time for rebuttals. So the timer is going. You guys have 2 minutes to prepare your rebuttal and then come up and present. And you'll get 3 minutes to present. They're leaving the room. Wow. They both get to, yeah. There's going to be like 2. No, let's do it at the same time. Sure. Great, whatever. Well, they're both doing rebuttals right now, it looks like. I have to go out and get them. I'm so... Just a reminder, if you have questions for either group, you can put them in the chat, and we're going to do that after the rebuttals. Okay, are you guys ready for your rebuttal? Well, you have to be, you don't have any more time. So come on up and give it. We'll stay up here and I'll just have this here so you guys can see it. 3 minutes for the rebuttal. Here.
All right, so I actually really enjoyed the presentation for the Plex team, so thank you so much for bringing all those wonderful points. I think the main thing that we were getting points for Plex were the time, which I think everybody that's going to start Plex starts it for that same reason. You want to get time for all your therapies to work, but the thing is, because we have all these new therapies, we don't know whether things like, the avacopan, maybe not avacopan, that's not a good, so let's not go there. But, you have all these new therapeutics that are coming down the line that might have better time to survival and give time for, that oil spill to stop without the risk of the infection and all these other things, which granted in the proposed trial that the other team gave us, if you have prophylaxis and all these things, et cetera, you might be able to do away with it, but it still doesn't stop the fact that they need a quintin, that they need all these citrate and albumin. So it doesn't stop the fact that you still have, all of these things going on. That doesn't remove that. So the other thing is about your survival and death. You cannot uncouple, kidney recovery and mortality. What is the point of being off dialysis if you're dead? There's no point. You cannot uncouple both of those secondary outcomes. We are nephrologists. We do want to avoid having ESKD, but again, I don't think it's possible to uncouple those two outcomes. And then the thing, go ahead. Right, and then the other team was making really great points about Pexivas versus MEPEX, but you can't really compare those two trials like they very eloquently presented. They were on very different populations, but looking at the Pexivas trial with a microscope, you can tell that the Pexivas cohort having 704 patients compared to 160 some patients, you are including that severe population that's in the MEPEX trial. And again, it does show no evidence in kidney survival outcomes, ESKD survival outcomes, all of that. And then to the point about the difference in, the kilograms per deciliter or, the plasma exchanges, the reason that ASFA has those guidelines is actually very interesting. I had a Plex rotation a few weeks ago. There is no difference of having more removal of your immunoglobulin when you increase the blood volume. There's no difference. So why give these people more volume when you have no difference?
All right. Thank you very much. No ProPlex rebuttal?
Okay, go ahead. All right. Thank you to our colleagues as well. We really appreciate the discussion. So our colleagues are really emphasizing the risks of the procedure itself, so let's dissect this a little bit. Number one, the risk of infection. We don't have any conclusive evidence that the procedure itself increases risk of infection. The type of population that we're treating with this therapy are routinely receiving immunosuppression. There's also some emerging evidence that the vasculitis disease state in and of itself may increase infection risk as well. And so that's one issue. The other thing is that when you look at the supplemental material that's available in these trials regarding infection risk, they describe it as stage 3 or category 3, and this is a designation that implies that IV antibiotics and hospitalization are required for treatment of these infections. But I think for any patient who is staring down the barrel of the risk of dialysis, a lot of them would accept a short-term increased risk of infection for a few months or up to a year off of dialysis. They also comment on risk of bleeding and risk of citrate toxicity, and every institution has active protocols for checking fibrinogen, for monitoring for citrate accumulation or citrate toxicity, and avoiding hypocalcemia and other electrolyte derangements. And so this is a very active area that we try to avoid based on institutionalized protocols. Our colleagues also commented on the real-world data towards the end of their trial, indicating that the most severe kidney patients did not see benefit, but I want to point out that those data points were exclusively from observational studies. And specifically, when we talk about the strengths of Pexivas in terms of its size, my worry about that is that despite its size, I think the generalizability is limited. As our colleagues reviewed, the conclusion criteria included a GFR less than 50. Only about 20% of the initial baseline cohort was on dialysis, and as we reviewed, only a third of the patients had severe AKI. So when there's a signal towards benefit in our most severely affected patients, it's hard to extrapolate that from the Pexivas study. Even though the size is large, it's hard to extrapolate that information because the patients who stand to benefit the most are not well represented.
And also, we did mention about the checking antibody titers level. This is something we do routinely for anti-GBM disease. And I know like the Pheresis guideline does not say that for the vasculitis, and that is predominantly because we don't have any study that is supporting it. All right.
Okay, so for the questions, I'd actually like to invite both teams to come up and maybe we can have each table. You guys can share. There's only 4 seats, so figure that out. You guys are good friends. And this way we can all answer questions together. Oh, yeah. You guys can... Well, you want the microphones, so you're too hyped up? Okay. As long as they can hear your answers. So the first question was about Avacopan, so I feel like we should just skip that one. Sorry, we're not talking about Avacopan today. Okay, so for Proplex, while you have made a case for need for more data and hence for a well-designed RCT, is it ethical to treat outside of the trial setting?
Well, to answer that question, currently we do have a practice point even within the guidelines supporting or at least considering the use of plasma exchange when the creatinine is greater than 3.4. And this is based off what we have right now and the understanding that we didn't do sufficient plex possibly. So I think we have enough evidence to use plasma exchange. It's not like we are doing outside of the guidelines or outside of the evidence so far.
With evidence, it wouldn't be a practice point.
Yeah. That's a good point, and that is what we. So that is something that we did mention, that when we have a supporting or a positive outcome in a meta-analysis of randomized controlled trial, we would have had a recommendation which could have been grade 1. The only reason that wasn't the case was because of increased risk of infection. And I think we do have, like this was based on the meta-analysis, the increased risk of infection. That is why I had the slide where we did look at the increased risk coming from Pexivas, which didn't show increased risk of infection.
If you're recommending a randomized controlled trial, it means that you have equipoise, and if you have equipoise, you can't make a recommendation one way or the other.
So no, I was mentioning about the meta-analysis of randomized controlled trials showing positive outcomes.
But if you're recommending a randomized controlled trial, it means you've got equipoise.
All right. What was the cause of mortality in MEPEX? I guess anyone can answer that. Yeah.
There is evidence of infection and also hemorrhage.
Okay.
Yeah, I think something like 19 patients had pulmonary hemorrhage, and there were some that had coagulopathy and infection. And the authors wrote that they believe that those causes of coagulopathy infection, all of those were actually plex-derived. That's what they wrote in their discussion.
At 12 months?
I'm sorry?
Was it still the cause at the month 12?
Yes.
Go ahead.
Yes. At 12 months, yes.
Oh.
Yes.
I just want to add to that. We just discussed that most of these effects of plasma exchange are like limited to a few weeks to months, especially when it comes to the coagulation factors and all. And I do think like in the MEPIC study, they did mention that the adverse events between the two groups was not statistically significant.
And I would like to add that you cannot compare PLEX in years after when you're doing PLEX at the beginning of the study when you're doing it the first 5 days. So you cannot compare something mortality-wise in that timeline when you do something at the very beginning.
I do want to add to that statement
Okay.
that we can extrapolate renal outcomes, because if you are able to bring someone off dialysis within a few weeks and monitor them off dialysis, I think that doing a few weeks to remove the antibodies and study the renal outcome makes sense.
Okay, for both, we're done. For both teams, are you aware of any data on how patients view the treatment choice and trade-offs?
Can you repeat, sorry?
Are you aware of any data on how patients view the treatment choice and trade-offs?
Actually, this might be for both of us, actually. It was a very interesting, the BSR guidelines, the British Society of Rheumatology, they actually talk about what Samadi was saying about the infection risk. So a lot of these patients, and I also read about another trial where they actually went and asked these patients what they preferred, and it really depends, and I think that's where our recommendation comes through. You have these patients that might have GFRs of 10 that are very close to needing dialysis. So this question mark whether they're going to be off dialysis or not with PLEX is kind of moot. They are going to be okay with getting a dialysis catheter if they're going to risk, being septic in the ICU. And on the other side, if someone has a creatinine of 2 with GFRs of, right below 50 with those patients that were included in the MEPEX trial, those patients might be okay with that risk of infection and risk being in the ICU if it can avoid a few days in the, sorry, go ahead.
I just want to add that.
And then the blood product that we talked about, yeah.
Just want to add to that yes, it's patient preference, but in our ECRD cohort, when we go, all of us go to dialysis, every patient in there wants to get off dialysis. I don't think anyone would choose to go to dialysis just because there is a theoretical risk of infection.
I mean, I don't think we should make assumptions. I think I agree with you that we have to cater to the individual, but we do have reasonable qualitative level data about the symptom burden that patients experience on dialysis, the impact on quality of life, the psychological burden that having chronic kidney disease and managed with dialysis has on their daily life. And so I think it's reasonable to extrapolate that information to this population and say that generally speaking, patients would want to avoid dialysis, but of course we have to practice on an individualized level.
Hi everyone, thank you for the great talks and presentations. I am not as good nephrologist as all of the other people, but I'm a little nerdy and I can also get into sophistication conversation to the point that the both competing teams will unite and come and beat me. So with that said, I want to say that when you use the metaphor of oil spill, I think we should clarify what kind of oil we're talking about, because petroleum oil is just dirty and nasty, and it will not go away. It has to be clean. If we are talking about vegetable oil, because they are still carried with the tankers, big tankers, well, who cares about that? It will be just dissolved. And then what if we have corrosive oils, such as hydraulic oils or brake oils, that they not only they won't go away, but also they will cause further damage and in everywhere. So that's the thing. So now I want to with that, I will go with my layman term of using the antibody and everything, which is that if I were the ProPlex team, instead of and what, I did not hear why these plex were working for your cases and were not. I think if we want to design a trial, we should, first have a better understanding of the pathophysiology of how the ANCA antibodies are going to, do the damage. What is their survival rate? How long they're going to last in our circulation, and what is the rate of de novo production? And with those, I think I genuinely do not know the answer to these, but why don't we measure the titers and making a decision based on those? Maybe the more senior.
Yeah,
attendants.
thank you.
And one more thing, sorry, about the risk of infection and also when to do that and when to not to do that. If that baby, I think, I'm not a pediatric nephrologist, but if a baby who just had placental autoantibody translocation, I don't see any benefit of giving rituximab to that neonate. So, thank you.
Okay, thank you. Do the judges need any more clarification, or are we ready for judging? Okay.
I would like to add just one more thing.
Oh, okay.
For the audience in general, our judges, they have specific criteria that they're following to decide for a winner. I don't think this is absolutely needed to bring up, but I feel like it's a good thing to bring up that does not mean whoever winner it is, that there is a correct or an incorrect one. That's the whole point of this. So our winner choice is not a medical guideline in any way. It's a practice point.
This will be a practice point.
And
number one.
And in that sense, since our judges have already finished their judging, I would like to maybe one representative of each team, if you were to get together and decide one point to give the audience out of all of this, to get everything together. If one of you from each team could do that, I think that would be very beneficial for the audience.
Yeah, okay.
So, like one take-home point, taking both of your teams together outside of the judging.
As we did discuss, yes, clicks for very specialized patient with very
This is not part of the judging.
Yeah.
It's okay. Do you guys want to go first?
Sorry, we're getting our brains together. But I think similar to what Samani was saying is you have to think about PLEX in the right patient population. So if you take a step back and you look at what we both presented, we're talking about risk of infection, whether it's from PLEX or whether it's from something else, you still have it there. You can't take it away. Whether you're talking about whether Pexivas had the right number of patients or not, you still have the potential of not removing ESKD out of the picture. So I think if you're looking at the patients that have DAH, that are needing to be ventilated, that have RPGN, and they're coming in from a creatinine of 0.5 to a creatinine of 4, we're not going to argue that PLEX is the right indication for this patient population. Those patients are potentially going to be the ones that have the most benefit from PLEX. Whether they have infection risk or not, whether they're going to be off dialysis in a few years or in a few months or not, those are the patients that might benefit from PLEX. The general population, if you remember that bell curve that we showed, those 80% of patients who are going to be, the ones that you're biopsying and waiting for the results to come back, waiting for potentially those ANCA antibodies that the other team wants to obtain, those are going to be the patients that you have to think about whether PLEX is reasonable or not to get in this patient. So I think just like we do with another area of debate, contrast, talking about the risk of benefits in these patients, but I think that area on the right side of that curve that I showed you are the patients that should get PLEX.
Thank you. Is there anything you want to add? If you don't...
All right. The evidence in this area is very nuanced, and we don't support the use of PLEX in the general population, I think the big takeaway is that with any intervention, there is a risk-benefit balance. And I think in this particular situation, the most severely affected patients, those who are threatened by the possibility of being put on machines, those are the ones who stand to benefit the most from plasma exchange. Those are situations when we are throwing everything we have at that patient. The other thing I want to say is that we will always put the patient at the center. And if they value time off of dialysis, then yes, we're going to offer plasma exchange to them in the most severe cases. There's ways to mitigate the complications that have been mentioned by our colleagues here. And I think at the end of the day, it comes down to risk-benefit balance and what is valued most by the patient.
Thank you very much.
All right, thanks everyone. All right, well, first off, a wonderful job. These fellows have been working very hard on these presentations and probably not enjoying the conference as much as they would have liked. But I think the spirit of this in the third year we've done it is that we wanted these colleagues to meet other fellows from other institutions, get to know them, and work together as a team to learn something new. And I think all of you are going to go back and be experts on this topic, which is amazing. And thanks for sharing it with us. Thank you.
Thank you. Thank you so much.
All right. Well, I do have a lot of conflicts because I coached one team and I have a fellow on the other team. So I feel confident that either team that wins, I'll be happy. So without further ado, the winner of NephMadness National Invitational Tournament 2026 Fellows Debate is Team Plex. Congratulations.
And I will also say it was very close. So everyone did an amazing job.
It was very
and
good.
yes.
No problem.
Yes. Thank you so much to our judges and to the audience. And we'll definitely we want to get a picture. Oh.
Yeah, that's okay. It's your event.
I worked so hard.
All right. Another round of applause. Thank you very much. Thank all of you for coming.
Thank you.
You guys all together.